Welcome to AHA Early Career Blog. I am Zain UL Abideen Asad, Assistant Professor of Medicine, Cardiovascular Section, University of Oklahoma Health Sciences Center. We are going to discuss management of atrial fibrillation in patients with heart failure and reduced ejection fraction. I have the honor and privilege of having Dr. Rakesh Gopinathannair with me today, who's the lead author on the recent AHA scientific statement on management of atrial fibrillation in patients with heart failure and reduced ejection fraction. Dr. Gopinathannair is currently the Director of Cardiac Electrophysiology at Kansas City Heart Rhythm Institute, Professor of Medicine at University of Missouri Columbia, and Adjunct Associate Professor at University of Louisville School of Medicine. He currently serves as Chair for the Heart Rhythm Society Communications Committee and the American Association National Electrocardiography and Arrhythmias Committee. He's also a member of the AHA Clinical Cardiology Council Leadership and American College of Cardiology's National Electrophysiology Leadership Council. Following graduation from University of Kerala, India, he completed a Master of Arts in Exercise Physiology from University of Maryland, internal medicine residency from Hahnemann University Hospital, Drexel University College of Medicine in Philadelphia, and then cardiology and cardiac electrophysiology fellowships from University of Iowa Hospitals and Clinics. He then served as assistant professor, associate professor, and director of cardiac electrophysiology at the University of Louisville School of Medicine in Louisville, Kentucky. He serves as an associate editor for Heart Rhythm Case Reports and section editor for Circulation, Arrhythmia, and Electrophysiology. Dr. Gopinathannair has served as a writing group member and peer reviewer for AHA, ACC, HRS, and AHRQ guidelines, and writing committee chair for AHA's scientific statements. He peer reviews for leading cardiovascular journals like JACC, European Heart Journal, Heart Rhythm, JACC-EP, Circulation Research, JAHA, and Circulation, Arrhythmia, and Electrophysiology, among many others. He served as chair of the National Electrophysiology Clinical Standards Committee for Catholic Health Initiatives from 2013 to 16, a large national healthcare organization with 97 hospitals across the country, and has been instrumental in developing EP clinical standards and quality metrics across this large healthcare network. He has published 290 peer-reviewed articles and abstract presentations, along with several book chapters, and has been an invited speaker at multiple national and international meetings. He's a prolific researcher, and his research interests mainly focus on arrhythmia-induced cardiomyopathies, COVID-19 and cardiac arrhythmias, and implantable device therapy, and complex arrhythmias in patients with advanced heart failure and left ventricular assist devices. Welcome, Dr. Gopinathannair. Thank you so much for joining us today.
Thank you, Zain. I appreciate the opportunity, and thanks for the kind introduction.
So, Dr. Gopinathannair, can you tell us briefly about this AHA scientific statement on managing atrial fibrillation in patients with heart failure and reduced ejection fraction, and briefly highlight what are the major updates to this document as compared to the most recent ACC, AHA, and HRS guidelines on atrial fibrillation?
So, this particular topic, AF management in heart failure with reduced ejection fraction, and if you look at the origins of it, one of the first major trials that looked at it is the AF-CHF trial, which compared rate control with rhythm control using antiarrhythmic therapy. And that showed that there was no significant difference in outcomes. There have been some issues with the trial, but this has become sort of a treatment paradigm was that, rate rhythm control is fine. And then of late, there are several randomized studies that looked at this using non-pharmacological approaches to rhythm control, including catheter ablation. And these have, in my mind, kind of created a paradigm shift in how we manage these patients. The ACC, the 2019 AHA-ACC HRS guideline update gave a 2B indication for the catheter ablation. It essentially said AF catheter ablation may be reasonable in selected patients with symptomatic AF and heart failure and reduced ejection fraction to potentially lower mortality and reduce hospitalizations. And however, the most recent European Society of Cardiology guidelines clearly, they have given a class 1 indication for, and they support catheter ablation as a first-line therapy for AF patients with HFrEF with the following recommendations. So to reverse LV dysfunction in patients with AF and tachycardia-induced cardiomyopathy, when you suspect that, that is highly probable. And the another point is independent of their symptom status. You don't necessarily need to have, you can do rhythm control using catheter ablation to prevent worsening of heart failure and cardiomyopathy. And secondly, it should be, they also give a class 1 recommendation to, actually, sorry, it's a class 2A recommendation for patients. It can be considered in select patients with AF and HFrEF to improve survival and reduce hospitalization. So it's an upgrade from, so compared to the AHA-ACC guidelines in 2019. So our goal here was to provide this is a very critical field, and we see this all the time, and AF and HFrEF can be pathophysiology-wise, they're related, they can worsen each other, they can be the cause as well as consequence of each other. So I think it's our idea, thought was to create a truly multidisciplinary document, a scientific statement, which and to provide the state-of-the-art data on that, as well as to provide a consensus on what the suggestions or considerations or implications for clinical management in this particular area, which has been seeing more and more quality data. And we also wanted to highlight the gaps in knowledge, as well as provide thoughts about what should future research consider, along with providing a sort of a framework or a paradigm for clinical management of these patients, summarized in a figure. So that was the whole idea behind it. And I think with these sort of with the available data and difference in guideline directions, this was just to give a more clinically relevant document that a clinician can easily access, and hopefully to help them in their day-to-day practice and management of these patients.
Okay. Thank you so much for summarizing that. Can you briefly tell us about the recent evidence that has favored rhythm control approach in patients with heart failure and reduced ejection fraction and atrial fibrillation?
So there have been at least 4 to 5 randomized trials in the recent years, and the ATAC trial was the first one to specifically look at this particular group. In that particular trial, patients were randomized. These are all patients with heart failure and cardiomyopathy, and they all had implantable devices. The ATAC trial randomized patients to amiodarone with cardioversion and to catheter ablation, and they These were persistent AFib patients, and they looked at AF recurrence as a primary endpoint, whereas mortality and hospitalization were secondary endpoints. And they showed that compared to amiodarone, catheter ablation resulted in maintenance of sinus rhythm in a significantly higher proportion of patients. Moreover, they noted significant excuse me, significant reduction in mortality, which is the first such trial to show a mortality benefit with catheter ablation in HFrEF patients, and also significantly lower hospitalizations in the AF ablation group. So the CASTLE AF trial, which followed, was still the largest study to date that I should say the RAFT AF, which was recently presented in ACC, had more patients, but that study was stopped prematurely. So CASTLE had about 363 patients, paroxysmal and persistent AF, with an ICD or CRTD, and they compared patients, they randomized patients with catheter ablation versus medical therapy, which included 70% had rate control, rest of them had rhythm control. And they had a primary endpoint, which is a composite of mortality and heart failure hospitalization, and again showed significant improvement in survival and reduction in heart failure hospitalization with catheter ablation. And this has pretty long follow-up, 60 months. And the couple of key points that came out of CASTLE was that the benefit or the clinical benefit was associated strongly with reduction in burden of atrial fibrillation. So it is not a binary thing. You don't really need the patient to stay in sinus rhythm 100% of the time. Even if you can reduce their burden down to less than 20% or less than even less than 30%, they benefited. So it's some cumulative reduction in AF compared to absolute maintenance of normal rhythm was important. And I think that's a key point as kind of may guide some of the future studies in terms of what endpoints to use in terms of ablation or rhythm control in these patients, basically. And there are some criticisms about the study too, and they include, there was higher than expected mortality in both groups. So there was some, even though guideline-directed medical therapy was clearly followed in both the medication dosings and were not reported. There was the obviously generalization of this is a little tricky because these are very clear inclusion-exclusion criteria. These people, there is crossover, 15% crossover from one, and then 15 to 19%. But if you look at AFCHF also, there were a lot of crossover, and but even in the rate control arm, 40% of the patients were in sinus rhythm. So it was kind of a but if you clearly look at on-treatment analysis, and people who underwent ablation benefited a lot in that regard. So that's the camera MRI is another important trial, even though very small, which actually looked at AF ablation versus rate control therapy. These are very well rate controlled patients who, who had a portion of them had underlying structural heart disease by MRI, and they compared these patients and they found that, but the endpoint was not survival. It looked at EF improvement. They found that even in well rate controlled AF patients with heart failure and reduced ejection fraction, catheter ablation or rhythm control with catheter ablation substantially improved EF compared to rate control alone. And when you look at the patients who had scar in MRI, those patients did not have the same degree of EF improvement compared to those who did not have scar, but the improvement in EF in the patients who had MRI scar was significantly better than in the rhythm control arm when compared to rate control arm. So meaning that even if you have underlying structural heart disease, it should not preclude you from uh, you know, initiating rhythm control with catheter ablation. So what's the point here? The point is that it's likely that patients, even in those who have underlying structural heart disease, there is a there is what we call as an occult arrhythmia-induced cardiomyopathy that can be corrected by rhythm control and which cannot be corrected by rate control. And so we're not talking about tachycardia per se. These are very well rate controlled people. It's just that AF as a rhythm itself can, even rate control AF can worsen EF and cardiomyopathy in that case. So these are the three main ones. And then AMICA was another study that looked at a more sicker heart failure population and compared rate control versus ablation and found no difference. But the trial was stopped early for futility and clear conclusions cannot be drawn. The only thing that sort of came out of that was, it was looking at EF improvement. The only thing that came out of it was like, if you are really worse heart failure or, cardiomyopathy, the outcomes with ablation may be lesser compared to those with better, better NYHA class or probably little bit better EF, and the more recent one, RAFT AF, which was just presented, it's not published yet, I believe, and similar as Castle, there is a Canadian consortium study and 411 patients followed up for 37 months, I believe, and if you look at the intention to treat analysis, they didn't have, again, the study was stopped prematurely because of didn't meet the event rate endpoint. But if you look at the data, it's very clear that those who underwent ablation did better. They even from heart failure hospitalization, even if you look at functional class, and even in the overall composite, it was like a 0.06 p-value. But I think, but if they had more events and longer follow-up, it would have been a positive trial, in my opinion. So I think it kind of goes along with what ATAC and Castle showed and not a substantially different picture. Cabana had a subgroup analysis of heart failure patients who in the intention to treat analysis, and they also substantially benefited from catheter ablation compared to medical therapy. So if cumulatively, I think the burden of data right now in this particular population favors rhythm control strategy using catheter ablation compared to antiarrhythmic therapy or rate control therapy. And so that's the overall consensus on the information. I mean, again, you can argue about different studies, sample sizes and all that, but I think the idea to reduce AF burden by a non-pharmacological approach has been pretty solidified based on available data.
So that was a fantastic summary. And, as I see it in the last 4 or 5 years, it's trial after trial, not only limited to, the heart failure and reduced EF population, but other patient populations, especially, paroxysmal AFib. Seems like the whole field and paradigm is shifting towards, ablation and, more importantly, early ablation. And it seems like most of these therapies are now targeted at improving your AFib burden as opposed to looking at AFib just as a binary entity. So thank you for highlighting all that evidence. And, going through the AHA scientific statement, which you are the lead author on, my most favorite part of this document is how beautifully you have distilled all this evidence into very nice patient selection and decision-making tool, which clinicians can look at and make quick decisions. So can you elaborate on how do we apply all that evidence and take into account patient selection and identify patients that are most likely to offer to benefit from catheter ablation?
Yes, the fundamental management principles for both AF and heart failure doesn't change. I mean, you still do guideline-directed heart failure therapies, and obviously there are a lot of new, therapies for heart failure that is available. Lifestyle and risk factor modification is very important as management strategy in atrial fibrillation, especially post-ablation, where that can be very helpful. This primarily include managing high blood pressure, weight loss, sleep apnea treatment, diabetes management, smoking, and excessive alcohol use, physical activity, those kind of things. You obviously anticoagulate them using CHATS2 score. Rate control should be initiated if the rates are not controlled, and it's not unreasonable to, if there is a patient needs cardioversion for symptom control or heart failure control, that should be done. I mean, you don't want to pursue catheter ablation and decompensate the patient, but this is more of an elective therapy for long-term improvement in this case. So short-term, you manage the patient to improve their heart failure. And then, once the patient, once you institute these things, in my mind, regardless of symptoms, it should be evaluated for catheter ablation. And then with the idea that, patients who are, you suspect AF-induced cardiomyopathy, I like the term arrhythmia-induced cardiomyopathy rather than tachycardia, because as I mentioned, even rate-controlled AF can cause cardiomyopathy. And then, assess their eligibility. I mean, are they, is their functional class reasonable? Consider assessing an imaging modality to see if there is any scarring, if there is any substantial, LA size, fibrosis, all those things, and do they have long-standing persistent AF versus recently persistent or paroxysmal, age and other comorbidities, all that. I'm not saying that the people who have more advanced heart failure and scarring shouldn't be excluded completely, but it's just more of a clinical assessment to give the patient a better realistic expectation as to what to expect. And then if that fits, I think they should undergo catheter ablation. And if they can, then some kind of monitoring would be very useful in these patients, because to assess burden, as I mentioned, and also to assess for recurrences. And because in people with, especially in those with arrhythmia-induced cardiomyopathy, if there is recurrent arrhythmia, they can have recurrent myopathy. And so those are things to watch for. And some people could need more than one procedure, and that's been shown that that can be helpful. Let's say the patient is not eligible, or if the patient has failed repeat ablation plus minus antiarrhythmic therapy, then you have options of pharmacological rate control. If that doesn't work, then you have the option of doing AV node ablation with either pacemaker or ICD or CRT if the patient, depending upon criteria, or consider antiarrhythmic therapy. The choices here include mostly, dofetilide or amiodarone, and depending upon patient characteristics, when they have renal dysfunction or hepatic dysfunction or any other, and then those are things could be considered with or without cardioversion. And so I think, this can probably serve as a guide to, and everybody is different. I think we have to individualize it, but this is a construct that can be used to pursue management strategies in these patients.
So this is like, a wonderful decision-making tool. And to all the audience, I'll highly encourage that if you don't have time to go through the whole document, at least look at figure 3 of the document that highlights, like, which patient population is more likely to benefit from ablation or early rhythm control. And as Dr. Gopinathannair summarized beautifully, it's usually patients in which you are suspecting arrhythmia-induced cardiomyopathy and by HA1 to 2 symptoms, no significant scarring, minimal or less atrial fibrosis, and paroxysmal or early persistent AF, and generally younger patients with fewer comorbidities. So these are, again, general principles which you can always tailor to your individual patients. So Dr. Gopinathannair, in the end, can you please highlight some of the knowledge gaps and areas for future research, including the role of appendage closure in this specific patient population?
So obviously, left atrial appendage closure has is an alternative to long-term anticoagulation for stroke prevention in patients who have, who can tolerate short-term oral anticoagulation, but they're not suitable candidates for long-term oral anticoagulation. Specifically, the endocardial closure, which is a more commonly done type, and they even though we don't have specific data on heart failure patients per se in terms of how the efficacy, safety, and impact on these patients, but on the other hand, I don't think there is any reason one shouldn't be offering appendage closure. They meet indications, even if they have heart failure or cardiomyopathy. There's some emerging data in this field which looking primarily at epicardial exclusion devices such as AtriClip or Lariat ligation, and there have been a couple of papers from our group that looked at renin-angiotensin, aldosterone axis, and some of the other neurohormonal markers as well as blood pressure, and we found that significant reduction in blood pressure which is persistent at a year follow-up, as well as neurohormonal markers in patients who undergo epicardial exclusion compared to endocardial occlusion devices. So again, these are hypothesis generating data, but I think it's an area that it's prime for future studies in terms of better understanding the. So again, I think the indications for appendage closure doesn't necessarily change if you have HFrEF in my mind, but I think we need more targeted studies in this population.
All right. Thank you so much for your valuable time. It was a pleasure having you, and hopefully we'll have you back for further AH early career blogs.
Thank you for the invite, and I appreciate the opportunity to be here.